Great to see everyone's face, albeit covered up by masks, but it's good to be back in person after all these years. We'll go over a special type or a certain segment of rotator cuff injuries. We'll talk about what is the state of the art of massive irreparable cuff tears in 2022-2023. So I'm sure if I asked the audience, almost everyone would know someone who's had a rotator cuff tear. They're obviously very common. They can lead to significant pain. Can't tell you how many patients come in and they tell me, well, it really hurts at night. It hurts if I try and lift my arm. It hurts trying to take my sweater off or something along those lines. It can lead to significant disability, especially the larger cuff tears. If you see a patient or someone just even out in the street who has difficulty lifting their arm, like John McCain, the former senator, those are usually massive cuff tears. So we're talking about a special breed of rotator cuff injury. The treatment of rotator cuff tears in general is going to depend on a multitude of factors that I've listed here. We talk about the number of tendons involved. There's 4 rotator cuff muscles and tendons. If we're talking about 2 or more, we have a massive cuff tear. The degree of retraction, the degree of atrophy. So this is where the adage, if you don't use it, you lose it, applies. If the muscle and the tendon are not being utilized the way it normally is, the muscle will start to atrophy, and it can even be replaced by fatty tissue. And then we talk about the tendon quality. So here are some arthroscopic images of 3 different types of rotator cuff tears, ranging from smaller cuff tear to the left to a massive, scary-looking cuff tear on the right. And the way we manage those is obviously very different. And we'll go over the different options. In general, with rotator cuff repairs, the way we will treat them surgically is we use suture anchors, and we can use 1 row of rotator cuff anchors for, say, a smaller cuff tear. For most tears that we see, which we would characterize as moderate to large, we'll use 2 rows. So this is an example of double row repair, where the anchor goes into the bone. The anchor has stitches or sutures that come out. We pass those sutures through the tendon, and then typically we'll try and lay the sutures on the top surface of the tendon and then anchor them again somewhere out laterally. Why do we do that? Because this tends to be a very strong biomechanical construct, and we're trying to enhance the biology by really getting the tendon squeezed down on the bone to get it to heal. So this really brings to light the 2 major concepts that I want to get across here. When we're dealing with large irreparable cuff tears, we have a biomechanical problem and we have a biologic problem. So when you see something like this on an MRI, if you're an orthopedic surgeon, your heart just kind of sinks. This is an example. Imagine the patient is facing you and the slice is going up and down. What we see, I don't know if this probably doesn't show up here, but that's the ball, that's the socket. This is where the rotator cuff tendon is. That's a completely different zip code. So this is a naked humeral head. That humeral head is completely uncovered, and that's a big problem. When you look at it arthroscopically, what you see here, if you're looking at it from the side, the camera's coming from the side, the ball is just underneath us, and we're staring at the socket, and the rotator cuff tendon is way out over here. So, unless you're a magician, I don't know how you get that tendon back down to that ball. And that's a huge problem. Even if you could, it typically doesn't heal because the rotator cuff is under so much tension that's just not a very biologically conducive environment to get it to heal. So these are the types of injuries we're talking about. Typically, these types of patients, again, they may present with severe difficulty elevating their arm. You may even see some of these patients when you go to the restaurant and you see them try to grab a cup of water. Instead of drinking it like this, they drink it like this because their shoulder doesn't externally rotate. So over the last 5 to 10 years, we've tried something called superior capsular reconstruction. This is a technique to try and address the biomechanics of the problem we have here, where the ball starts to rise up because the rotator cuff can't do its job because it's pretty much not even there. So the deltoid is overpowering the rotator cuff. The ball cannot be centered on the socket, and because the deltoid, the vector line goes up, it brings the ball up. And so instead of pivoting off the socket, the ball now pivots off the acromion. Bad problem. So what we're trying to do here is we take a dermal allograft. So you can think of it as a decellularized or acellular type of skin graft. Originally, this was described by a surgeon in Japan where they used fasciolata. But you take a decellularized allograft, and it's important that it's decellularized because when we tried it in the past, and if you have any cells, the body can reject it. So this typically does not get rejected. In addition, the nice thing is it's off the shelf. So it comes in a box upstairs. If we need to use it on the fly, I tell the OR nurse, they bring it out, and we can use it like that. You lay it on top of the ball and socket, and you just anchor it to the glenoid or the socket, and on the humeral side, you anchor it to the greater tuberosity. And, the results have been pretty good in the short to medium term, but there are some issues that we need to be aware of. One is the rate of failure is related or inversely related to the thickness or the strength of the graft. So if we use a thinner graft, it typically can tear over time, and you need it to heal. So we talked about how it's good that it's acellular. Basically, it's not living. The problem with that is acellular structures are kind of dead. And so we need our cells to sort of populate that graft to take it over and make it viable. And if we don't, then it stands over time because of the repetitive type of stresses it sees, it can sort of rupture or tear. Now, this technique just got approved last year by the FDA. It's been used in Europe and Israel, so it's been used internationally over the last 10 to 15 years. It sounds like some sort of space-age device, but really, it's pretty simple. Again, we're trying to address the mechanics of a ball that's not centered on the socket. And the way we do that in this technique is we're actually going to insert a balloon. You put a balloon in and you fill it up with saline, and then you kind of get them moving pretty quick. So it's technically pretty simple. The first surgery I showed you is actually kind of hard. This one is pretty simple. The recovery is typically easier. And in the case series that have been published internationally, it seems to work pretty well. When they compared it in more rigorous studies, the results have been a little bit more mixed. We're still hoping we can work out the kinks because this would be a nice way of doing things. But we have to be honest that at this point, it may work well, and you can see in this x-ray how it sort of gets the ball to come down. It may work well. It tends to biodegrade over the course of a year, and so we have to see what the results will be after a couple of years. And then the last way we can address these types of injuries is with tendon transfers. All right, so we talked about addressing mechanical issues, and we try to do that also with tendon transfers. And here we're taking something that is living, so we're using the patient's own muscle and tendon. And transfers have been around forever. The granddaddy for rotator cuff transfers is the latissimus dorsi transfer. It's been around probably 30 years. And what we're doing is we're taking the tendon that attaches to the front of the humerus, and we're sort of bringing it around the back of the shoulder, under the deltoid, and attaching it to the greater tuberosity. And when this was first published, I think in '88 by a European surgeon, it really got people excited, and we still use it. It can help to bring elevation up, help to improve the patient's ability to lift the arm, and in younger patients, especially laborers, people who really can't go to the shoulder replacement type alternative treatment yet, I think it's a good option. It also doesn't involve the use of allograft, which we'll touch upon in the next slide. The one downside is that we're taking a muscle tendon unit that is involved in extending, internally rotating, and adducting the shoulder, and we're trying to get it to do almost the opposite. So it's not necessarily in line with the fibers of the rotator cuff. If you look here, these fibers are going this way, these fibers are coming up. So the results are less predictable maybe than we'd like, but it still is a good option. We do use it for younger patients. We also use it for patients who do have certain forms of shoulder replacement. So it's something I think that everybody should be aware of. And then the more recent type of transfer we've been not experimenting, but using is the lower trapezius transfer. Here we're taking a portion of the trapezius that attaches to the lower part of the scapular spine. It's over here. And we're taking it off and attaching an Achilles allograft to it to give it the extra length to get it all the way to the greater tuberosity, which is where the rotator cuff should be. Now the advantage of this is that actually it is in line, for the most part, with the muscles of the rotator cuff. So it can be good to improve their external rotation and their elevation to some degree. In general, with these tendon transfers, they do seem to work better when the condition is a little less severe. If people can't get their elevation preoperatively above 60, 70 degrees, this doesn't tend to work as well. But it is something to consider, and I think that it is fairly promising. Now, people also ask me about, well, what about PRP, stem cells, those types of things? Well, tons of studies have been done with PRP and rotator cuff tears and rotator cuff surgery. If we're honest, the results are somewhat mixed. If we look at the meta-analysis data where we're pooling all the studies together, there probably is a slightly lower re-tear rate in smaller cuff tears with PRP. For the larger cuff tears, I mean, if it's a younger patient, sometimes we do, if we're honest, throw the kitchen sink at it and maybe throw PRP and stem cells and all that. But whether there's actual data for that, no one can really show, or at least no one has really presented that yet. Stem cells, there's very limited data. Typically, we won't use it. And then we talked about the allografts in the previous slide. So the allografts have been shown to, sometimes we use them to augment rotator cuff repairs, meaning if the tendon is thinned out, we'll also put a little layer of that allograft on top to give it some extra mechanical support, and that does seem to work. And so in conclusion, of course these are a significant challenge. We're talking about the biologic and mechanical issues, and if we're looking at treatment options, it's either we live with it, we do physical therapy, we do an arthroscopic procedure where we debride and possibly do something for the bicep. Maybe we do a partial rotator cuff repair where we don't bring it all the way to its attachment site, but try to repair it to some degree, or we do the other procedures we talked about. Otherwise, it's a reverse total shoulder replacement. But I do think some of these things we touched upon, you're going to see more and more over the next few years, so it's good to be aware of them. What we see, though, is that these are salvage procedures, okay? If there was one great surgery, like a hip replacement, everybody would be doing it. There isn't one great surgery. These are good surgeries for what we're dealing with, but they're not perfect.